Good afternoon. Thank you for joining me today. And today we will be talking about diagnosis and treatment of breast cancer with specific focus on treatment of early stage HER2 amplified breast cancer. My name is Dragana Tomic. I'm a medical oncologist and hematologist at the Northwestern Medicine Regional Medical Group. We are filming this at the Warrenville Cancer Center. If you have any questions during my talk, just post them in the comment section and I will be able to answer them if the time allowed. So the breast cancer is the cancer that starts in the breast, and from the breast it can move two ways. It can move from the breast through the lymphatics into the regional axillary lymph node, or it can go from the breast to the blood vessels to the other parts of the body. When a woman is diagnosed with a breast cancer, the first thing that we want to evaluate, the extent of the disease. This is called staging. For staging for breast cancer, we used T and M staging system, where T stands for the size of the tumor, N is telling us if the cancer have moved to the lymph nodes and how many lymph nodes are involved. And M is telling us if the cancer has spread outside of the breast, chest wall, and regional lymph nodes. The staging for breast cancer can be clinical staging and pathological stage. The clinical stage means that we are evaluating the extent of a disease prior to surgery. So to evaluate the clinical stage, we use physical exam, and we evaluate the extent of a disease by looking at the mammograms, the breast ultrasound, MRI of the breast, so imaging studies. The pathological stage is a stage of a disease that is determined after surgery. And for pathological stage, we use the information from the clinical staging, but we look specifically at the pathology report after the cancer is removed from the breast. The pathologist will tell us what is the size of the tumor and if the tumor have moved to any regional lymph nodes. So the stage for breast cancer can be stage 0, 1, 2, 3, and 4. The stage 0 breast cancer is non-invasive breast cancer. It's called ductal carcinoma in situ. And this means that these are the cancer cells that they're incorporated in the duct in the breast. In theory, we don't think that they are moving outside of the breast. Now, the invasive breast cancer can be stage 1, 2, 3, and 4. The stage 1 breast cancer is when there is the least amount of cancer in the breast. If there is a bigger lump in the breast or the cancer have moved to the regional lymph node, it's a stage 2 or 3 breast cancer. And unfortunately, if the cancer have moved outside of the breast, it is outside of the breast, chest wall, and lymph nodes, and we can detect it in the other organs of the body, is a stage 4 or metastatic breast cancer. The treatment for stage 4 breast cancer is systemic therapy, but moving forward, we will be focusing on early stage breast cancer, early stage invasive breast cancer, stage 1, 2, or 3. So the treatment for early stage breast cancer is local therapy and systemic therapy. Local therapy is surgery, which means remove the cancer from the breast, and plus minus radiation treatment with the goal of decreasing the chance of cancer coming back locally in the breast. Systemic therapy is something that goes into your blood, and that is the chemotherapy, antihormonal therapy, and targeted anti-HER2 therapy. So when a woman is diagnosed with the breast cancer, during her cancer journey, she will meet with a breast surgeon who will be talking to her about the breast surgery. She will meet with radiation oncology, potentially most of the time after surgery, and they will be talking about the role of radiation to the breast. And then they would meet with medical oncologists to talk about systemic therapy. So when I see a patient to talk about systemic therapy, if I see that patient prior to surgery, I'm evaluating the extent of a disease by looking at the imaging studies, and then I look at the pathology report from the biopsy. And there I look at 4 specific features that are really important for the prognosis and progression and outcome for breast cancer. And this is a grade of the tumor, presence of the estrogen receptor, progesterone receptor, and HER2 receptor on the cell surface. These 4 features are incorporated in the newer staging system together with the T&M staging. So the grade of the tumor is something that pathologist tells me on the path report, and it basically indicates how aggressive the cells look under the microscope. The breast cancer can be grade 1, which is the least invasive looking cells, grade 2, or it can be grade 3, which is the most aggressive looking cells under the microscope. And then on every cancer cell, nowadays our pathologists are reporting the expression of the estrogen and progesterone receptors and the HER2 receptor. So estrogen progesterone receptor positive cancers, they are called hormone receptor positive cancers, and that means that they are feeding off estrogen. So around 80% of breast cancers are hormone receptor positive cancer, and what that means to us, we know that we will be recommending anti-hormonal therapy to these patients, which is anti-estrogen therapy or a pill that women will take for 5 to 10 years. Women who had estrogen receptor negative breast cancer will not benefit from anti-hormonal therapy. And then the fourth thing that we actually look at the path report is the presence of the HER2 amplification. HER2 amplified breast cancer, they represent around 15 to 20% of breast cancer. And what that means, they means that they have HER2 receptor exposed or present at the cell surface. So in the past, the HER2 amplification meant a worse prognosis because we knew that these cancers were not responding well to the classical chemotherapy. However, in the meantime, we have developed the targeted anti-HER2 antibody, which are the antibody that bind to the HER2 receptor on the cell surface, and they can kill cancer cells. And one of the first anti-HER2 antibody that we have been using, that we are using now, is called Herceptin. And since then, there are additional antibodies that are incorporated in the systemic therapy, including pertuzumab, as well as antibody drug conjugate, which is called TDM1 or Kadcyla, that all of them we are using actually now for treatment of early stage invasive breast cancer. What we learned about this anti-HER2 antibody is that, number one, we have to combine the antibody with the chemotherapy to start with, and then there were multiple studies looking at how long the patient should receive the antibody, and we learned that they should actually receive the antibody to start antibody with the chemotherapy and then continue receiving antibody after the end of chemotherapy to complete the 12 months of treatment. Now, this HER2 amplified breast cancer can be estrogen receptor positive, which means if I see a patient with HER2 amplified breast cancer that is estrogen receptor positive, in addition to chemotherapy with anti-HER2 therapy, I will be thinking about adding anti-hormonal therapy. And this HER2 amplified breast cancer can be estrogen receptor negative, and as I said, these patients will be just a candidate for chemotherapy in combination with anti-HER2 therapy. So in the past, if someone would, if woman would be diagnosed with early stage HER2 amplified breast cancer, and if she had resectable disease, she would see the breast surgeon first. She would have surgery, and then after surgery, she would see the medical oncologist, and then the medical oncologist, we would be basically looking at the pathological stage. We would be looking at the path report from the cancer that's removed from the body, and then we would be talking to them about the chemotherapy and anti-HER2 therapy. What we then learned is that this combination of chemotherapy and anti-HER2 therapy is very potent. It can actually shrink the tumor significantly, and if we give this systemic therapy prior to surgery, we can achieve a couple of things. Number one, we can shrink the tumor. So by shrinking the tumor in the breast, the patients who would need, let's say, mastectomy, they would potentially be a candidate for less invasive surgery like lumpectomy. Then by giving systemic therapy prior to surgery, we can shrink the tumor in the lymph nodes. So if someone would require axillary lymph node resection prior to surgery, if we would give these women chemotherapy and anti-HER2 therapy prior to surgery, and if we can shrink the tumor in the breast, they may be a candidate for sentinel lymph node biopsy, which would mean less axillary lymph node surgery and can potentially decrease the risk of lymphedema or swelling in the arm. And the third very important thing that we learned about is that if we give systemic therapy prior to surgery, it's actually called neoadjuvant chemo and immunotherapy. We can evaluate the response to treatment, and based on the response to treatment, we can actually evaluate the prognosis for this breast cancer, and we can act on the results after surgery. So specifically what that means, if I see a patient, so if there is a patient nowadays who have a breast cancer that is a HER2 amplified and it's a bigger cancer in the breast or has a lymph node involvement, most of these patients can actually feel the lump in the breast, and more likely if they have a good performance status and good cardiac function, they will end up seeing the medical oncologist prior to surgery. So if we give these patients the chemotherapy and anti-HER2 therapy, during the process of receiving systemic therapy, I usually see my patients every couple of weeks, and we actually evaluate the response to treatment. We can evaluate response to treatment usually with a physical exam, and I would like to see the breast lump becoming softer or smaller. And then the patient proceed with surgery, and then after surgery I see them again back in my office. So now we are looking at the pathology report, and on the pathology report, our pathologist, if the patient have received systemic therapy prior to surgery, will tell us if there is any cancer cell left, what is the cellularity of the specimen, is there a cancer spread into the lymph nodes, and we will be actually able to evaluate the response to systemic therapy. So if there is no cancer left on the pathology report after neoadjuvant systemic therapy, that is called a complete pathological response. And we know that women who had complete pathological response, they will have a much better prognosis than women who have cancer cells left after the neoadjuvant chemotherapy and surgery. So these women who have pathological complete response, these are the women that we will still continue treating with anti-HER2 therapy, but we kind of have a happy dance and we're all happy because there is actually a very good response to the systemic therapy. But if a person received chemotherapy, had surgery, come to see me in the office, and there is still cancer cell left in the breast or in the lymph nodes, that person did not achieve pathological complete response. But at this point, we will be able to act on that information. So this is the person that I will not treat with anti-HER2 antibody, but this is the person that we will give an antibody drug conjugate that's called TDM1 or Kadcyla, because we have a study showing that if we treat these women with Kadcyla, we can actually improve their outcome. Saying this, I just don't want everyone now to think that if there is a HER2 amplified breast cancer, if you have HER2-positive breast cancer, that everyone should have systemic therapy up front. There is a still group of patients who are diagnosed early, who have a very small tumor in the breast. And if there's a very small tumor in the breast and there is no clinical lymph node involvement, this is still a group of patients who should have surgery up front, because these patients, when they see us after surgery, may be a candidate for less invasive systemic therapy. So when we see our patients, as I said, prior to surgery, we try not to overtreat patients. So I think all of this actually just emphasized the importance of multidisciplinary approach to treating breast cancer. So this is when you have breast cancer, as I mentioned, you'll be seeing medical oncologist, radiation oncologist, you'll be seeing a surgeon, and I think it's really important that, that we communicate among each other. So we are doing that by having our weekly, at least here at the Warren Mead Cancer Center, we have our weekly breast cancer tumor boards where our surgeons are presenting every case. We have a discussion there with surgeons, with medical oncologists, with radiation oncologists. We have our pathologist there to review the path report. We have our radiologist to show us the breast imaging. And then together we are actually determining which patients should potentially have systemic therapy prior to surgery, or which patients should actually proceed with surgery upfront.
Okay. Mm-hmm. What exactly does HER2 positive mean? Like, you talked a little bit about how it's on the cell receptor. Mm-hmm. And so, like, what causes it to be positive or negative?
So the HER2 amplification means that there is a gene in the cell that is causing the expression of this HER2 protein. And how we know that the cancer is HER2 amplified? Well, we know that because this is what the pathologist will tell us, because on every cancer cell, they will do some specific studies. Initially, they can do IHC staining study or a FISH study to actually determine the presence of the receptor on the cell surface, or to determine if this HER2 gene is amplified. And as I said, the importance of that is because in the past we just knew that these women would do worse with the chemotherapy. But nowadays, if there's a HER2 amplified breast cancer, we know that we will be using targeted anti-HER2 therapy combined with the systemic chemotherapy, and that really significantly improved the outcome and made this HER2 amplified breast cancer highly treatable disease.
And does having a close relative with HER2 positive breast cancer increase a person's risk for breast cancer or being a HER2 positive breast cancer patient?
So there are, for every patient that we see in our office, we evaluate the family history. Because there are certain genes that can run in your family that can increase the risk of breast cancer. If the woman is diagnosed with breast cancer at early age, if there is a family history of breast cancer, family history of ovarian cancer, skin melanoma, other cancers in the family, this is the group of patients that we will send to our genetic counselors for genetic testing. In the past, we used to test people just for something called BRCA1 and BRCA2 mutation, but now there is a much larger panel of genes that we test people for. And I think that we are learning more and more that the breast cancer, especially diagnosed at the earlier age, may actually mean that there is a genetic predisposition. Now, mostly people who have the presence of BRCA mutation actually increase the risk of triple negative breast cancer. So I can't really make a connection with HER2 amplified breast cancer, but I think for every patient, especially patient diagnosed with breast cancer at their younger age, is really important to go through family history and to obtain a genetic testing.
And what is the outlook for HER2 positive breast cancers?
Well, I think that, outlook 10 years ago or 15 years ago wasn't that great, but I think nowadays we are developing new treatment. We are learning more and more about the breast cancer, and this is becoming a treatable disease.
And you talked about the benefits of having chemo before surgery. Are there any risks associated with having chemo before surgery?
So when we give systemic therapy prior to surgery, one thing that, as I mentioned, you don't want to do is that you don't want to over-treat the patient. So if a patient have a very small tumor in the breast and negative lymph nodes, and if I think that this is a person that may benefit from less chemotherapy after surgery, then this is not a person that I would like to give more aggressive systemic therapy prior to surgery. The second thing is that during the systemic therapy prior to surgery, we have a very close eye on these patients because you want to see cancer shrinking. You don't want to see cancer becoming bigger or growing through the systemic therapy. So this is why I mentioned it is very frequent. Every couple of weeks we see our patients, we do the physical exam, and I always tell my patients, you will be the first one who will actually see the difference. Because the lump that you see right now, after a couple of weeks, we would like that lump to become softer. We want that lump to become smaller, to shrink. And then, since these patients are usually seen by a surgeon up front, our breast surgeons are seeing them in the middle of the neoadjuvant chemotherapy, so they can evaluate the response to treatment too.
Okay, and I think last question: what is the risk of a HER2-positive breast cancer in recurrence?
So that really depends on multiple features. That is such a difficult question to answer, because it depends on a stage, right? It depends on the extent of the tumor in the breast. It depends on the extent, if the tumor is present in the lymph node or it's not in the lymph node. But then it does, I think it depends if it's estrogen positive HER2 amplified or estrogen negative HER2 amplified. But then it depends how well the women are actually responding to the systemic therapy if they are receiving systemic therapy prior to surgery. So I think that if we give people if we give women systemic therapy prior to surgery, we can potentially, that will help us answer that question after the surgery. Thank you.